Now I have the privilege of introducing our moderator for the rest of this of today's webinar, and that is Melissa Harvey. Melissa is the Assistant Vice President for Enterprise Emergency Operations for HCA Healthcare. She has over a decade of federal healthcare experience and is one of the nation's most trusted experts on healthcare system preparedness. You can read much more about the depth of her experience in the bio that we're putting into the chat right now. And as I turn it over to you, Melissa, I'll just say I've been so grateful for your counsel since the inception of the Common Health Coalition. You've guided so many of our efforts on emergency preparedness. And so we're grateful to you for that and for moderating the conversation today. Over to you.
Thank you so much, Dave, and thank you to the Common Health Coalition and all the partners that brought this group together. We're really excited to welcome our speakers today, Onora Lien, who's the Executive Director of the Northwest Healthcare Response Network, Dr. Paul Biddinger, who's the Chief Preparedness and Continuity Officer of Massachusetts General Brigham. Also has a role in the Region 1 Regional Disaster Health Response System and the Region 1 Regional Emerging Special Pathogens Treatment Center, it's a mouthful, as well as Dr. Vikram Mukherjee, who's the Chief of Critical Care and Special Pathogen Medical Director at New York City Health and Hospitals in Bellevue. He also has a role in the National Emerging Special Pathogens Training and Education Center, as well as the National Special Pathogen System, and the Regional Emerging Special Pathogens Treatment Center for Region 2. So we have a lot of great partners here who can share their expertise and the tremendous roles that they've played in bringing together all these partnerships that we saw on the prior slide that you all contributed to that are so vital to emergency preparedness. The topic of today's discussion is about always on preparedness. And for me, that really means not just bringing the partners to the table, but developing the systems that we need to have in place, whether that's about data collection, whether it's about how we're going to share staff and supplies, how we're going to maintain that constant visibility every day about what's happening in our public health and healthcare systems, so that we don't have to turn it on and off for emergencies, but perhaps it's more of a dimmer switch that is always on, but maybe perhaps dialed a little bit lower at times and stronger at other times. And recently, I know inside of my health system, we've really been stressing with our clinical teams, our clinical leaders, the importance of the activation of our incident command systems, no matter how formal and structured they are or how loose they are, but thinking through just the day-to-day strain that we have in healthcare. No one's hospitals are empty anymore. Everyone is full to capacity all the time. And there's reasons for that. Sometimes it's because of an emergency. Sometimes it's just because of daily strain. But having an awareness of, are the four walls of my hospital the only ones experiencing this in my community? Is there a way to better balance this out equitably so that the patients can receive the right care in the right facilities in a timely manner? Or is there truly something going on that we need to be tipped off about and have those partnerships at the table to be able to discuss? That's really what always on means to me, is having that ready so we don't need to develop the systems in the first few weeks of the emergency, and they're always ready to go. We hope listeners today are going to share their ideas with us, share their awareness, and really leave here with a sense of what they can possibly do in their own communities to implement and instill an always-on readiness structure, both at their own organizations and inside of their communities. So I'm going to ask all of you to use the chat to share any questions that you might have with our panelists throughout their presentations today. And also tell us in the chat about any challenges that your organization's facing with staying always on, as well as any unique strategies that you've employed and used to really maintain that always on preparedness. So Rebecca, if you'll just put that into the chat as a question so that we can have our audience constantly chime in on that throughout, that would be wonderful. So I'm going to start by turning this over now. We'll start with Paul. We'll start with you and then move on to Onora and then Vikram. Really just briefly introduce yourselves and say a bit about your role and a little bit about the area of your response infrastructure.
Yeah, thanks so much, Melissa. Thank you to the Common Health Coalition. It's really a pleasure to join everybody here. I am Paul Biddinger. I'm an emergency physician by practice, but I really have two halves of my life. For one half of my life, run the emergency preparedness program for my health system, and on the other, I work on some federal projects funded through the Administration for Strategic Preparedness and Response, the Regional Disaster Health Response System, and the Regional Emerging Special Pathogen Treatment Center for the New England region, Region 1. And I think maybe, the most important thing I'd like to focus on is actually that regional disaster health response system effort. Right now, there are four programs in the United States. Ours in Region 1 and the Nebraska program started at the very end of 2018. And since then, we've been joined by programs in Colorado and in Emory, covering 4 of the 10 HHS regions. When the program was first started, it was really a pilot. It was meant to be a way to bring hospitals together to create a community for catastrophic emergencies, to really plan for the big one, as it were, that oftentimes doesn't quite get the planning attention as the more likely daily events. And we created 3 big goals for ourselves. We wanted to create a community among all of the hospitals of New England, but particularly the bigger hospitals, the trauma centers, the pediatric hospitals, those with disaster capabilities that might be more needed if there were a big event of any kind, whether it's infectious disease or trauma, others. Secondly, we wanted to have a mechanism for the way that hospitals could come together, especially across state lines, because either in coalition or state lines, we have some pretty good mechanisms for hospitals to collaborate. But when we start spilling across state lines, it gets a lot murkier. And thirdly, we wanted to try and augment some of the strained capacity of the healthcare system in a disaster by creating things like disaster telemedical programs or deployable disaster teams that would complement things that are available at the federal level, like the DMAT teams through HHS. And what we found is that even though the program started at the end of 2018, and we really were just barely getting going when the pandemic started in early 2020, there was such value in creating a community. It relates to a lot of what you were just talking about always on and having people ready to come together. Not as badly as New York, but the Boston area was pretty hard hit in that first wave of COVID. And we were able to leverage those relationships, just starting to create an RDHRS, to do some of that first level loading, some of that load balancing that later became a little more common in the Boston area when our ICUs were bursting at the seams. And we're pretty proud of the fact that we never ran out of ventilators, never ran out of ICU beds, never really ran out of those critical care resources that were under such strain. As we've continued to grow, and now, of course, we're on the other side of COVID, I'd say that people really continue to support the RDHRS and buy in, I think, a lot because we see it honestly as a mutual aid kind of endeavor. Any one of us can imagine that we're in some sort of catastrophic disaster scenario. We might have to evacuate our hospital, or maybe it's our hospital plus a couple of our neighbor hospitals in some sort of severe weather event. If the grid fails, there are other scenarios, obviously, that would matter. And if we need it, we want others to be able to be there in a coordinated fashion so that we can have the support and the receiving resources that we need. Similarly, we want to be able to be there for our neighbors if we're not affected, but someone else is. And I think because everyone can really envision themselves either in a receiving or a giving support kind of mode, and they recognize that across state lines, across hospitals with those most scarce care capabilities, there's value here. We've had great engagement. And maybe the last thing I'll just say is building on what you talked about the hospitals being full, and I think just the way hospital care is transforming still across the United States. All of the big systems, and we have a lot of big systems of healthcare across New England, recognize that it is essential that we always have the right patient in the right bed, in the right institution at the right time, because our resources are so under strain. And there really is no system where you can have someone who understands complex medical care, can look at hospital beds across a large region, understand differences in hospital capabilities, unless you build a system that has that depth of knowledge, that breadth of scope. And so we've been building that with our RDHRS. We've been building it with our public health partners in the 6 New England states. And that partnership between the RDHRS and public health obviously is absolutely essential for its success. But we're pleased with what we've been able to do. I think there's a lot still to do for not just us, but I think across the region, but happy to talk more as we continue in this panel.
Thank you so much, Paul. And it's amazing to see what the Region 1 RDHRS has done. I know it feels like 2018 was a long time ago, but it takes a while to build these systems. And so we're grateful for what you've done. Onora, let's turn it over to you for an introduction and a little more about your network.
Sure. Well, good morning from the West Coast, and thanks to the Common Health Coalition. It's a pleasure to be here this morning, and I'll echo some common themes that we've heard already, but I'm Onora Lien. I'm the Executive Director of the Northwest Healthcare Response Network. We're a nonprofit organization. We serve as the backbone for a coalition of healthcare, public health, emergency response, private sector, many others, with a specific focus on building healthcare resilience and readiness for a wide range of emergencies and disasters. And we do that through a coalition model, engaging really whoever needs to be at the table in order to accomplish better readiness and response capabilities. I've had the opportunity, we've been a nonprofit organization now for over 10 years. We started as a program within a local public health department here in the greater Seattle area. As an organization, and I'll ask if we can pull up a couple of slides just for those who aren't as familiar with the Pacific Northwest geography. We started as an organization in local public health Seattle, King County. Over the last 20 years have grown this work really based on the evolution of healthcare and a kind of a continuous appreciation for the interdependency within healthcare in our geography. So over the last 10 years, and certainly lessons learned from COVID and other healthcare responses, especially given what we've already heard in terms of the changing landscape, we've grown over the last 10 years from what started as a 2-county effort as a nonprofit to now serving most of Washington state. And that includes collaboration with our partners in the Southwest and certainly collaboration where appropriate and necessary on the borders with other states. But as an organization, we, if you can see color in this solid green area, serve this large region. And we, the next slide, really focus our work, again, with a center point on looking at how do we build and ensure systems with a focus on resilience, readiness, and response capabilities. We really focus our work across the kind of disaster management cycle before, during, and after in 4 major buckets, ensuring a common operating picture across the status of our healthcare ecosystem. That practically means on a daily basis, a deep dive on what's going on from a hospital capacity perspective. What are the constraints we're seeing in long-term care? What are the issues we're seeing if there's a part of one of our communities that's dealing with divert or facilities that need to be on or off because something is going on, issues that are affecting the ongoing sort of baseline readiness and capabilities for healthcare to respond if something happens. We're collating that information, providing that information, and ensuring we have common ways to report through the various databases our state uses and that hospitals and other partners have agreed to share across our region. We focus on building innovative and kind of solution-focused, response-ready plans, tools, resources to help healthcare organizations in collaboration with public health be ready to respond to whatever comes next. That takes a lot of different shapes and forms, much like Dr. Biddinger was talking about, helping to build in collaboration with Harborview Medical Center and our Washington Medical Coordination Center, our regional medical operating center model that serves as a partnership between us and our WMCC and our hospitals around the state to be able to do daily load balancing across the state, but also to ensure that there's a system that we can leverage in the event that there's smaller mass casualty incidents or larger surge scenarios that require coordination across the state to make sure that the right patient can get to the right place at the right time. It's also about building tools and resources to help organizations think through clinical strategies for scarce resource management, to look at strategies for sheltering in place within healthcare organizations or evacuation if necessary, strategies and tools to help guide decision-making around for hospitals that are taking the approach to implement policies for respiratory masking in patient care areas or not, creating collaborative processes and tools for organizations to work with that. we maintain a kind of always-on posture. I love the focus of this organization, the Common Health Coalition. It really aligns with our mission because we really are, as an organization, focused on being able to respond at any time. That includes a 24/7 duty officer and a posture that is always ready to escalate, depending on what the need of our healthcare and public health partners is in the community, and then making sure we're not just doing the day-to-day work, but also helping to improve our systems through policy and engaging thought leaders and the voices that need to help us improve our systems on a daily basis through policy or improved plans or legislation, et cetera. It's lots to talk about in terms of the work that we do. And I think I will give an opportunity for my colleagues to finish their introduction so we can get into the meat of the discussion.
Thank you so much, Onora. I've always been so impressed with what the network has done. It's really, I think the vision of healthcare coalitions when they were first established by the Hospital Preparedness Program really had the vision that they would kind of expand and become what you've really been able to build out with the network. So thank you.
Thank you. Thanks.
All right, Vikram, we'll turn it over to you.
Thanks, Melissa. Tough act to follow after Paul and Onora's description there, but I'll try my best. My name is Vikram Mukherjee. I'm a critical care physician. I'm chief of critical care at Bellevue Hospital, the safety net hospital in New York City. But I also have the privilege of working in the world of special pathogens or high consequence infectious diseases, which basically means emerging pathogens that can cause a lot of community disruption, healthcare worker disruption, and given what we've seen over the last 10 years, pose a significant threat to our hospitals, to our healthcare workers, and to our communities at large. I do want to thank the CHC organizers and Melissa, you and Paul, of course, for having me here, and a large thank you to the audience who've taken time out from their busy schedules to come and attend this webinar. We've been working in the world of special pathogens for the last decade or so, and knowing well that, it's a matter of time before a novel infectious disease hits our shores and affects American biosecurity. We've learned from the last 10 years that, be it Ebola, be it Mpox, be it an early pandemic, we have to make sure that our healthcare workers are safe in being able to handle such situations, because I think all of us know that without healthcare worker safety, there is no healthcare being delivered, and we strongly focus on the healthcare worker, healthcare delivery aspect of things. We do want to make sure that a patient who has a suspected or an emerging pathogen gets the same standard of care that he or she would get if it wasn't a novel pathogen. It's pretty easy to forget about a patient or ignore a patient in a busy emergency room and leave him or her at their own mercy. But we do want to make sure that any patient who has one of these diseases gets the same level of care in an ICU or a biocontainment unit or an emergency room while keeping the healthcare workers safe. To Paul's earlier point about the pandemic, we in New York got hit hard, really hard in early, just around 5 years ago to this date. And I think what those memories bring true is that the response, while it was wholehearted, was fairly, at the end of the day, inequitable. And the societies, the communities that didn't have historical access to healthcare were the communities that died more often and got hit hard more often. So everything we do now is through the lens of an equitable framework. And Melissa, Paul, you've been intrinsic in building this national special pathogen system, which we'll talk about. But just a brief highlight there is, since the pandemic started, our funders, ASPR, recognize that the U.S. healthcare, there is no U.S. healthcare system in being able to handle high consequence diseases. And I think the writing's on the wall. We've had more than 1.2 million deaths from COVID as of now. We've had more than 110 million infections. And just beyond that, the economic cost of 16 trillion just shows that investment in preparedness is key in saving lives down the line. So under that framework, our funders have asked us to develop a framework for national special pathogens to make sure that the next outbreak that we have, be it Ebola, be it a respiratory pathogen, is a bit better handled. And a lot of the work that we're doing is making sure that at peacetime, there's coordination, there's understanding of each other's work, so that when there's wartime or so, we can easily build on those relationships to deliver a much more equitable, safe framework. So again, thank you for having me. Melissa, back to you.
Great. Thank you so much, Vikram. And I think, the work that you've all done with the NETAC has really shown that we can bring neighboring and oftentimes competitive healthcare systems together, to really learn from each other. I just know that every single time a facility receives a visit from the NETEC, they just sing the praises of all the participating different health systems in that effort, because it's truly collaborative and a great way to learn from each other. We're going to turn it over to just some specific questions now. And Paul, what I'd like to ask you a little more about it with the regional disaster health response system, two key points that you made in your opening remarks were it's sometimes murky bringing, especially other states all together and health systems from other states. So how did you perhaps in the last 7 years that this has really been around, how did you navigate that? How did you bring perhaps reluctant partners to the table and get them to stay? And then if you can also touch upon, I think everybody's a little bit concerned about government funding for some of these efforts for the future. Do you have advice for other parts of the country that maybe don't have a funded RDHRS about, how they can start to do some of this coordination in the way that RDHRS?
Webinar.
Nice.
Yep. There may be somebody off mute in the background, but yes, I think that's right. I think my answer to both of your questions is actually kind of similar. I think it's back to this concept of mutual aid, that, it's very hard to get people to collaborate on daily operations. Obviously, healthcare systems are, many of them across countries, struggling financially and struggling for market share. And really how they receive and how they manage patients is key to their success. So we try not to encroach too much in that territory. What we're really talking about is the gray sky, the black sky day, where something is so significant. And, there are pretty easy scenarios. Severe weather can affect almost anyone in the United States, maybe different kinds of severe weather, and can really damage our facilities or change ways in which our patient population is affected. We could have utility failures certainly anywhere. And I think we unfortunately can have mass casualty events absolutely anywhere, not just in urban areas where we have to distribute a large number of critically injured patients very quickly. And so talking through those scenarios, I think people can envision what they might look like and how stressed any hospital would be, whether you're a very large tertiary care center, or whether you're a small critical access hospital or community hospital. And that, I think, has been pretty compelling to get people to come together. And to your point about what do you do if you don't have an RDHRS, right? We still certainly have 6 of the 10 HHS regions that don't. I think that same concept has actually been kind of compelling, that you can think about that gray sky day and say, boy, I wish, we would start coming together and at least start doing a little bit of that scenario planning for what we could do as a group of healthcare organizations. And our RDHRS has talked to a couple of other regions around the country that have actually done exactly that. I think, the good news about emergency preparedness is that it's not a competitive field, and everybody in the middle of a crisis understands how we're going to have to come together. It's a good way to get people to buy in.
Amazing. I couldn't agree more. And you've done tremendous work there in Region 1. Onora, specifically for you, your coalition is perhaps a little bit different than some other coalitions. You mentioned that it's a 501c3 organization, and it doesn't operate solely with inside of government structures. And so can you talk to some of those who might be listening about, where do you start if you want to take your coalition in that direction, and how do you build from there?
Yeah, I think, as for HPP work, our coalition started because our healthcare and our public health had a vision of collaboration, the need to work together in spite of the competitive boundaries. That kind of common theme has grown as our organization has grown. And to Paul's point, a recognition that at some level there's kind of a neutral playing field, but there's also a recognition that we have to be intentional about the coordination that's needed in order to make these things happen. And so I appreciate that healthcare and public health leadership, more than a decade ago, kind of acknowledged that we need to create a kind of a backbone structure. We look at other social movements, social action activities, and often you have a backbone organization serving as that convening, coordinating, bringing people to common vision and common goal, and supporting those efforts. That is no different than what we've been able to accomplish. And I think as ASPR has been a really necessary and important tool in helping to support through the hospital preparedness program and other funding mechanisms, I think those are important. This work needs to be invested. At the same time, I think we need to look within communities to say, first, let's focus on figuring out where the shared value is, and then look within our communities to figure out where are there entities that can help support that? That may be through a traditional healthcare coalition model. There may be other organizations or other forums in your community that may actually be the right place. The key, I think, and what's been important for us is to figure out and really listen, I think, to healthcare and to public health about what's the need. Part of where we've been able to move the needle, I think, is really keeping an ear to the ground for what is actually going to add value for healthcare, what's going to help us move beyond the competitive dynamics that they deal with. And Paul outlined many of those core principles and core needs. It's also about listening to what public health needs and what the community needs, and trying to create the structures and processes that are going to support those community activities, create the connectiveness, recognize where can we all move in the same direction, and where do we need to allow for regional variability, but recognize that we have kind of a common shared vision. So starting with figure out what the common shared vision is. Where's the value and opportunity? It may not be all the things, it may be a subset of things. Looking within your community to who are the right partners and players that may be able to help support that. They may be different than some of your traditional emergency management partners. And start to build. And it's figuring out where can you get common agreement? Where can you start to take actionable steps? Where can you get alignment and kind of a commitment to keep moving forward in a common direction and build towards that?
Yeah, I mean, you make such a great point. Sometimes we, allow perfect to be the enemy of the good, and it's just kind of starting with a small bite-sized piece, and then we can really build from there.
I also, though, think it's important for folks to recognize where I think we all share on this call, the commitment that this really has to be something that isn't just the exception. It has to be something that we think about as a part of daily community need, daily business, and an essential business practice. It's important for our economies. It's important for the business bottom line that we're ready, that we're able to respond, that organizations are able to keep providing care to the community. And so that does require us to elevate the importance, but also to start to look in places beyond maybe the traditional niche emergency preparedness areas where we can start to leverage relationships, structures to start to integrate this as a part of other work and other more day-to-day practices that may help amplify it in communities where some of our traditional models may not be as receptive.
No, I love that. For so long, we've always tried to think through, how do you bring other partners like the major employers that are not related to healthcare and public health into this effort, because they really are critical. And that's such a good argument to make that they're going to need healthcare for their own employees. And so we need to build the coordination structures for them. Vikram, let's turn to you. So the National Special Pathogen System of Care is, it's so badly needed. I mean, we've had a trauma system. It looks a little different in every state, but we have had a trauma system for very, very long now. Talk to us a little bit about what you see the role of the NSPS being during, peacetime, when there's no emerging or re-emerging infectious disease kind of on the horizon. And then when we are in, national response mode, what would that system really look like?
Thanks, Melissa. Great question. You're right. We feel that, with the competing priorities of increasing global travel, climate change, increasing human population, such kind of outbreaks will be a matter of recurring frequency. And however, our shores have to be protected against such events, irrespective of where they arise in the world. So for the last few years, we've been building this National Special Pathogen System. Paul's been intrinsic, and many of this is the work of his brain trust. But what we've built together is a tiered system where we recognize that not every hospital across the US can take care safely of high-level critically ill patients with one of these horrible viruses. So we have a 4-tiered system. On the top of the tier is tier 1, or the RESPTCs. MassGen, Bellevue, 11 more across the country are among the top of this tier, and their role is to make sure they have capabilities, biocontainment capabilities for clinical care, but also have an added responsibility of making sure the rest of their HHS region is equally prepared to at least provide initial care, provide some lab testing, help with EMS transport, while making sure that healthcare workers are kept safe throughout all of this. So we have 13 of these RESPTCs, or level 1s, and around 40 of level 2s and so on. What glues this system together is NETEC, the National Emerging Special Pathogen Training and Education Center. We've been recognized by Congress as the coordinating body for NSPS, or the National Special Pathogen System, and we glue this system together to make sure that there is uniform guidance, standards, research going on, funding, advocacy, and so on. And I would just like to mention that, through all of this, we feel strongly that Peacetime is when preparedness happens, and the results of the work during peacetime, and I know I'm preaching to the choir here, is seen during a safe response during wartime. So in peacetime, for example, now we're doing a lot of training sessions, a lot of visits, like you mentioned, Melissa. We have an active research pathway for any of the countermeasures that might not be FDA approved for medications in these special pathogen situations, and an active international partnership arm so we can learn from our partners in Europe and LMICs in Eastern Asia to make sure that we are not completely siloed off. So a lot of work and advocacy going on during peacetime so that our response is safer than it has been in the past. Thank you.
Thank you. That takes partnerships now to a whole new international level. So I appreciate that. I'm going to now turn it really to all of you. So just chime in, as ideas come to your mind here. But we've all been watching what's been happening with H5N1, and now we have measles. This was a particularly important topic in my mind as well, with the number of Texas hospitals that we have here in HCA and some measles cases in some of our markets right now. So if you could give healthcare and public health leaders right now your own short list of actions that they should be taking, whether it's for H5N1, measles, or whatever the next thing might be, what are the handful of things that you really would tell them they should be doing in the next few weeks?
I might jump in. I don't have to always go first, but I think, I think the fundamentals are really still important. Back at the beginning of COVID, which again, both feels like a really long time ago and then not so much in some ways, we were all scrambling to make sure everybody could do donning and doffing safely of PPE. They knew how to wear PPE, how to select PPE, and the PPE you need for measles is different than the PPE potentially that you would wear for H5N1, depending on your circumstance. And I think going back to those basics, make sure that your frontline clinicians in the emergency department and the urgent care centers and the primary care centers and on the floors and in the ICUs know how to do that. Vikram's point about a safe healthcare workforce is absolutely critical. We know how important it is that we have to be able to assure the safety of our workforce, and that is good to pay forward. And I think unfortunately we've lost a lot of the vigilance we swore we would never lose when we were back in 2020 on that perspective. I think the other is that mantra of identify, isolate, and inform that the CDC developed, that is now supported by the Joint Commission standards for hospitals. It is the common algorithm to take the good history, find the exposure factors, know what are the diseases we're worried about, find them appropriately, isolate the patient, protect your healthcare workers. And that's, I think, part of how we keep these events from spreading. One last thing I do want to sneak in is just to sort of double down on something Vikram said about the National Special Pathogen and its drive to make safe care available to everyone across the U.S. Right now we have these 13 level 1 centers that are very sophisticated in how well they can take care of the most complicated pathogens. But then it gets really murky depending on where you are in the country, what your access might be to a hospital that can do that initial isolation, that can do diagnostics, complex care. And that just isn't right in rural areas and lots of other parts. And commend Vikram, the whole NSPS, the NETAC team for developing it. I think that's the principle, I think, of a lot of what we're talking about with the Common Health Coalition is everyone has access to a prepared and resilient healthcare system, public health system.
Thank you so much. Other thoughts from the rest of you?
I think Paul highlights a lot of the key issues, and from a healthcare delivery perspective, all of the fundamentals are the things that we should be focusing on. I think in any community, let's acknowledge this isn't just a governmental public health problem. It's also not just a healthcare problem. This is a public health problem, and it is about saving lives of kids, adults, our healthcare workforce, protecting our economy, trying to make it is fundamental to our collective well-being. So looking within our community and figuring out where's the risk that may be different in each community, understanding who can come to the table to help mitigate that risk, whether that's sharing information through different channels, looking for different trusted leaders that can help amplify and encourage steps that individuals can take to protect their loved ones. It is the partnership between public health and healthcare in getting out message, but also going back to the fundamentals that Paul started about. we know how to respond to diseases. We know that there's variability in those, but we have to be willing to come back to those core principles, but also those core partnerships. And this really is the time where public health and healthcare need to be talking with one another and working together on really focusing on what's the problem we need to solve for and who can we bring to the table, or what do we need to be doing to solve for that problem. Less about the what's my lane, what's your, or less about the either potential competitiveness or potential political nature of some of these, and more just like, what's the problem we have to solve for? Who do we bring to the table to solve for that problem? And let's never forget that it's about saving lives and protecting our community's health. With doing that, we're also protecting our economy. We're protecting a lot of things that we all have a stake in. Let's look at solutions and figure out the best path to get there.
Such an important point. I think about measles, and I think about, where do potentially exposed patients present? They come to the ER, even though you don't usually go to the ER to get a vaccine, right? Or unless you're experiencing symptoms. And so how do we use these partnerships to make sure that we're not losing all of these patients that might now be interested in vaccination by referring them to the public health department and expecting them to go make another appointment or take another step, but bring the partners to the table? Can we partner with them to make sure public health can deliver vaccines in our spaces and other kinds of unique strategies, so that way, we don't lose patients to follow up? Vikram, any thoughts from you?
Yeah, absolutely, Melissa. I was just going to echo what Onora was saying about the role of partnerships. I want to bring up a key vulnerability here that I think Paul has heard me mention for the last 5 years about the need for inter-systemic collaboration. I think many of our hospital chains work seamlessly among themselves vertically, but horizontal collaboration is still very, very in its infancy. And of course, there's many factors pronouncing that. But one of the things that we have, I think all of us have learned from the pandemic, that if you're able to load balance, like Onora's team does on the West Coast, across hospital systems, you save 1 out of 4 lives, 25% reduction in mortality when you move a patient from a strained ER to an unstrained ER. And just that simple collaboration can not just keep our hospitals somewhat afloat, but also have an immense potential in being able to save human lives. So I'd love to see that more. I think New York City is on the bottom of the list in being able to collaborate inter-systems. So some work to be done here internally. But that and any ways of learning from our early COVID experiences and amplifying surge would be integral to a safe H5N1 response. Thanks.
We'll give it about 2 or 3 minutes before we turn it over for some questions from the audience. But if any of you have any thoughts, again, going back to that value proposition, again, it's hard to sometimes make the case, particularly, Vikram, as we talk about, naming infectious disease level 1 hospitals. It's not always, the first thing that executives want to do. How do you make the case for leaders both to kind of step up to take on those roles, and then also just to, at the highest levels of organizations, to have leaders enable that collaboration for the employees that work for that health system?
Great question, Melissa. Maybe I'll start and then love to hear what Paul and Onora think. So I think that one of the messages that we try to propagate here is, whether you're prepared or not, these outbreaks are coming to your front lines. These are not something you can prevent by being in a shell. So might as well be prepared to keep your healthcare workers safe, because it's a matter of time before the next event hits us. We've seen over the pandemic years that there has been such a lot of healthcare worker attrition. Hundreds of thousands of nurses, respiratory therapists, physicians have been leaving. And one of the ways that we've been doing it here is to make sure that healthcare worker safety is advertised as a retention tool. And we take care of our healthcare workers, and we make them safe in their workplace, and hope that they stay in the business, in our systems, to be able to deliver high-risk patient care. But our mantra again is that whether you're prepared or not, these outbreaks are coming to your footsteps, so might as well use peacetime for preparedness efforts. Thank you.
Any other thoughts on the value proposition?
I don't think we have this totally figured out. I think the emergency preparedness field overall doesn't do a sufficient enough job. And I think we all need, we'd love more data, but let's look at what we do know. Vikram mentioned one, I think, important data point that we've seen in some of the literature, especially post the last couple of years. 1 in 4 lives, the impacts, excuse me, that we can have in terms of saving lives as a result of load balancing. You know, if we look at the traditional emergency management, what's the dollar saved for every dollar invested in mitigation and preparedness? We save $13, right? That's a pretty significant economic point that we should be considering. I think that translates in a lot of different ways to healthcare. We know that there's a relationship between the emergency preparedness work and the daily business focuses of healthcare organizations and public health, from a quality and patient safety perspective, from a risk mitigation perspective, from a supply chain perspective, and kind of continuing to be able to deliver business. So I think the more we can capitalize on those daily value needs, things that are imperative to the bottom line of organizations and communities, and make the connection to emergency preparedness and the importance of this piece of that in helping to advance those. I think that's important to engaging leaders. Not saying we've done it perfectly or have it all figured out, but I do think that that's part of the direction. And then I think really keeping in mind that this is about community health. This is about keeping our communities viable, whether you're a small rural community. It's about making sure people continue to get access. It's about keeping our workforce healthy, and kind of thinking about it not just as the switch that we have to turn on when the bad thing happens, but the systems that we have to have always going, the relationships that we have to have going and we need to nurture, and the core tenets of information sharing, relationships to move patients around, kind of expertise that we need for a wide variety. Like those should just be a part of our day-to-day, and integrating and building on those partnerships to continue to make that happen, however is meaningful in our community, I think is where we need to focus. But we also need other government and non-governmental partners to help us do that.
Absolutely. I mean, you raised such a great point. This is not just about load balancing during emergencies. I mean, if we had a great way of figuring out load balancing day to day, not only would it do first and foremost, which you mentioned, which is safer for the patient and improve access and equity, but just the sheer inefficiency we have and the amount of time it takes to coordinate transfers, you know, by individual facilities calling, you know, even doctors at the bedside and the ED and the ICU calling, you know, 10, 20, 15 different hospitals to try to find a placement for their patient. There's no doubt we can do better.
Yeah, and I mean, just two last things. If I don't wear my RDHRS hat, but I wear my daily sort of healthcare system hat, I think the ways in which a robust healthcare emergency management program is most appreciated by system leaders is in the much more common events we've had: supply chain interruptions, IV fluids, multiple different pharmaceuticals, others that have been almost across the country. We were heavily affected by CrowdStrike when that event happened and took offline about 40,000 of our computers. And those systems don't just help in the catastrophic disaster event, but help us be able to provide care on a daily basis, have continuity of care, and really make sure we do what we're supposed to do. As Onora said, you know, deliver healthcare to our patients. And I think that's a pretty powerful argument to the C-suite about why you need to continue to invest in emergency preparedness and have a good program. I think I'll come back one more time to what Vikram said, which is none of us knows what the event is that we might face, but somebody is going to face it. Give credit to Southwest Texas for the tragic Uvalde shooting that no one would have suspected in that community, that a small rural community, that they would be affected. But tragically it happened, but they had such a good system that the way they mobilized patient movement, blood products, communication, all of it was extraordinary. And I think that's what we should all be aspiring to, so that unfortunately when events like this happen, we rise to the occasion.
I'd love to echo that if I can. I mean, I echo the example for sure to our colleagues in Texas, but also just really underscoring the importance of being willing to show up for the smaller incidents. And that consistent through line is, I think, what helps people buy in, see value, get credibility, and start to build trust and relationships that may be new or unclear where they can really add value. It's the certainly for us, it's the smaller stuff and our willingness to keep showing up, keep people together, keep sharing information, create the pipelines so that information and that common operating picture can be available through large and small, is what makes people willing to come together in the big. If we turned it all off, it wouldn't be something that I think we would have the willingness to come back together for.
I think that's exactly right. Well, we do have one question from the audience, and that's, I love this one because it allows you to kind of think about your ideal world. And so if funding wasn't an issue, if, bringing partners to the table was really easy, in an ideal world, what is it that if you had 100% buy-in, what systems would you establish to ensure greater public health emergency preparedness and healthcare emergency preparedness capabilities and build on them? Where would you start?
I'm a big believer that we always need the backbone. So I say that not just in the investment. I think we need good data systems. We need consistent data systems for sharing information. We also need a willingness for organizations to come together, and that doesn't typically happen just because they will. It takes a sort of orchestration and coordination. So I think whatever the model is, we need to share good data. But we also need a willingness to come together, and I think that means having some sort of core infrastructure to make that possible. I think we need expertise that we can tap into. This is an evolving landscape. Hazards are evolving, the frequency of hazards. We need to study things. We also need to ensure that our best knowledge of how to respond to different diseases, to different environmental threats is there. So we have to have an investment that is able to continue to keep up with the changing landscape, that can provide the technical expertise and guidance to help those organizations and those individuals that may not be able to spend all of their time, but to sort of have that as an always on and available readiness. I would want to ensure that we always have a way to move patients, load balance, get them to the right level, that we start to address the gaps in disproportionate access between rural and urban care, that we recognize that the payers have an important part of ensuring that people can get to the right level of care, and that we are able to equalize as not only on a day-to-day basis, but also in emergencies, to ensure that there aren't other barriers that sort of help us or prevent us from getting to the ideal state of everybody getting the care that they need. And there's a lot of ways we can continue to chip away at those things. I'd also love to have a really resilient supply chain, and one that is domestically available, not as dependent on international resources all of the time, or at least where there's domestic redundancies. I'm sure there's some other things. Nate, I love your question. But those are some things that I'd want to see, and I'd want to make sure we were thinking about that across the continuum of healthcare, across the continuum of public health, and for all age groups.
It's interesting because
individuals.
I agree with you on that, especially on the data side. I often say it's like a chicken and egg game. If you had the data, it would help to create the value proposition, and it would help to really show the reason for the need for collaboration and highlighting this. And without that data, sometimes it's easy to pretend that we might not have the day-to-day problems that we have. Obviously, we see it during emergencies. Any other thoughts? Because we have a few other questions, so I'm happy to turn to those as well. But any other burning thoughts from our panelists on that question?
Just the one thought, Melissa, echoing what Onora was saying, that, I think all of us who've been in an emergency room lately has seen how bustling and how busy it is, with dozens of patients waiting for a hospital bed being taken. And just imagine having a disaster response in a busy ER that's already struggling to keep afloat. So using funds to build some form of a surge capacity so that you don't have to choose between treating an MI patient, a heart attack patient, versus a stroke patient versus a trauma patient, and then the additional burden, if you may, of a high consequent infectious disease patient. So building some form of surge capacity in our daily lives so that we can do everything that we're called to do in peacetime, but then also flex towards a response while not compromising care, would be immense. Easier said than done. I agree that an empty bed is often not seen kindly by the C-suite, but I think that building surge capacity is integral to any disaster response preparedness activities. Thank you.
Yeah, and I think I'm going to build on that a little bit. I think, one of the most important concepts just in general, I think, for preparedness is building based on reality. And I would argue that most of the hospitals still in this country have not really reevaluated their mass casualty plans or their surge plans based on the state of overcrowding of their systems that they're experiencing. And I'll be candid, I've said this otherwise publicly, that if we had to go through the Boston Marathon bombing, we're very proud of our response back in 2013, but if we had to go through it again in the current state of hospital crowding, it would be extraordinarily more challenging than what we faced, and it was certainly plenty challenging then. And so we're doing a lot to try and plan about how we're going to still resuscitate patients. We're still going to be able to do the things we needed to do when we have twice as many people in our hallways, twice as many beds beyond capacity in the inpatient environment. And so I think requiring hospitals, healthcare systems to acknowledge that reality is important. Actually, I think one of the best ways to do it are exercise programs. I think in the years immediately after 9/11, the country really exercised a lot. I think that was the first time we started bringing together a lot of the hospitals, EMS partners, public health partners, to confront some of the realities that maybe people had ignored about our vulnerability for different threat scenarios. I think we did it again with the old days of H5N1. When the first go round, we were worried about it in the early 2000s. We did a little more after Ebola. And I think to bring rigorous data-driven scenarios to the communities, to have people sit down and candidly talk about where their capacities and capabilities are, I think will provide a lot of incentive for us to move forward and maybe stop ignoring some of the real challenges that we conveniently kind of have blinders to right now.
Great. We just received a question in via email. And so what kind of data infrastructure do each of your organizations use to help with this information sharing and shared situational awareness?
I'm happy to start. We have a pretty multifaceted and quite frankly, sometimes still takes too much time to do all the things. We have a couple of systems that our state uses. Certainly there's the various syndromic systems that our state and local public health rely on and draw information from healthcare. We compile and coalesce a lot of that information. We have another administrative, two actually, databases that our state currently uses to track different forms of bed capacity. We pull that information together, produce it in a report. We monitor different syndromic and other surveillance information that's made available to us with our public health partners. We rely a lot on calls, frankly, and actually people talking to one another and sharing what's going on in order to bring together a synthesis of information. And we produce that through different tools that are available to us to produce reports. There's ways to streamline, automate. We still rely on a lot of manual processes for hospitals and other organizations to update their resource availability, bed availability in particular. We hope to improve that in our state, make things more automated, but it's a commitment to trying to make the best available information we can. And certainly I think there's ways to continue to improve that.
Yeah, we've built, I think, really robust dashboards and data reporting systems within my healthcare system, and I expect that's probably true for many, many systems, just because of, again, the economic pressures on healthcare. I would say that we've had some interesting discussions about more aggregate data sharing in ways that maybe are different than some others in the country. We've been talking about how we can maybe develop systems that share data, but slightly blinded in a small regional level. So there's lots of business and operational reasons that healthcare systems are not necessarily going to be willing to share the most granular level about what's happening, about what's happening in their organization. But if you can look across a city or across a county or across a region of a state, you can really constantly take the temperature. What is ICU occupancy? What is ED volume? What is hospital occupancy? And that way we're not always wondering, how do I compare to other people? We're all stressed, but some people are definitely more stressed than others. And if you have aggregate data that is localized enough to be reflective of the healthcare community you're in, I think it actually provides a nice way to let people know when they should take different surge actions, when the system's really at a new level versus it's just a bad day for that hospital or for that system.
No further comments from my end, Melissa.
Okay, great. We do have a few other comments. One of them, and we've talked a lot about funding and, ideal state, as well as kind of the value proposition, but this one's a little bit different. And Onora, maybe you could start us off here. As we prepare for a potential future where government funding may not be as robust for a lot of these programs, what strategies do you recommend that state and local leaders, as well as healthcare coalition leaders do to ensure that there's still connectivity and partnership across all these different geographical boundaries.
Melissa, you cut out for just a minute. Can you repeat the first part of the question?
Oh, sorry about that. Are you able to
That's
hear
okay.
me now? Okay.
I am.
Great. Yeah. So this one's a little bit more bleak, but about the concept of that we might not be able to rely on as much federal funding as we've been receiving. And so how do we continue to make sure that coordination does happen between and across boundaries, even if our funding levels decline?
Yeah, it's a real challenge. I mean, I think let's be very frank. Work requires investment, whether it's the federal investment we currently have or other investment. It takes resources, it takes people, it takes to bring folks together to create opportunities to share. So it is a risk when we look at potential fluctuations in funding. That said, I think every community and every organization needs to look at where there are partnerships that may be able to be leveraged. If you have something already that's working, this is the time to be having the conversation about how do we sustain that and looking at other opportunities to make the value proposition. I think we need to be more creative in looking at things that healthcare organizations already do that might help amplify the investment and collaboration between public health and healthcare, the CHNAs that hospitals are doing. Let's be more intentional about bringing the risks that we see to our surge and our response capabilities to those conversations and look at whether there are creative partnerships that can be leveraged. If there are other community health oriented systems and structures that are working in communities, maybe those are places to start to weave in some of the coordination that might be needed and plugging in. I think we have to not be afraid to plug into a coalition of coalitions. So there may be work that is working in a local community, and then this is kind of what's the way we're trying to approach. We don't want to replace anything that's working in a community. What we want to do is be a connection and a harness to bring those folks together. So those may happen through a coalition like mine. They may happen through other forums, but I think most importantly, have to recognize that we have to be intentional about collaborating and sharing information. And wherever we can find the node to do that, it has to start with the leadership and the willingness to see that as a priority and then drive to make that happen. And so really focusing on that vision and that commitment, and then looking intentionally to where that can be done and building on that.
Then for Paul and Vikram, on the special pathogen side for the regional treatment centers and even the need tech, I'd love your thoughts again about how we sustain that level of readiness, perhaps again with declining or diminishing federal funds.
Good question, Melissa. I'll go first, Paul, if it's okay. And I think, Sarah, that brings up your comment there is really, really pertinent. I don't know, we don't want to dive deep into politics, but as we recede from USAID and WHO and CDC and so on, and we cannot equip our international partners to test and treat and control diseases in their countries, the risk for these diseases to come over just exponentially increase. So, of course, that puts us at a bit of a higher threshold. I think we have to recognize that irrespective of what's happening in DC, the challenges don't go away, the threats don't go away, and keeping healthcare workers safe being our prerogative still remains central. I think, Melissa, stuff like these webinars, these coalitions that we're building here and build preparedness efforts locally and regionally are so key in advancing preparedness, breaking down the silos that we've conventionally lived in, making sure our public health and healthcare delivery partnerships are as strong and robust as ever would be one way to navigate this. And just kudos to you and Dave and the others here on this call for making this coalition happen. I think these events such as these, which help forge partnerships and keep these relationships warm, make it so much easier during a response to have that trusted partner to speak with. Thank you.
Thank you, Vikram. Couldn't agree more.
Sorry, no, I will definitely also agree. And I think, honestly, this forum, I think, is a perfect example of what we need to continue to lead on, which is convening groups that will share best practices, share examples. And I like Onora's use of the word backbone. I think there will hopefully always be some organizations that are willing to be a backbone, no matter what the funding does. And I don't want to say funding doesn't matter. It matters a lot. And it definitely changes what you can do. But I think for those that are willing with the resources they have to continue to step up and be that leader that bring others to the table to help kind of bang the drum for why this is important, hopefully that will continue irrespective of the level of funding. Similarly, I think sharing what works and what is successful in whatever environment we're in is really important. And again, I think this is a great venue, and the Common Health Coalition is a great way to get these things shared so that we can all benefit from each other's different approaches. But you know, none, I'll say I'm certainly not smart enough to claim that I know all the right answers and know how to do this. And so I'm thrilled to be able to get together with smart partners and learn from their success.
Amazing. Thank you. This has been just a phenomenal conversation. I'm going to maybe end with this last question here. You know, we've been just giving this theme just now of kind of doing more with less. And so are there ways that you all, either whether you're doing this now or can envision in the future, using AI and other tools to help with emergency preparedness or special pathogens response, you know, maintaining that always on presence, using kind of some of these tools that hopefully can make our lives a little bit simpler?
I think certainly we are eager to use AI in the communication space as much as anything for monitoring. You know, we've learned so much from COVID about misinformation, disinformation, and I think we've proved that we're pretty slow in the public health and healthcare space about how we respond and how we even know what's being said out there. I think there's a lot of ways we can use technology to have a much better finger on the pulse of what is being said and what people are feeling. And I think that's really important. It allows us to be more nimble and to respond faster. I think similarly, you know, there's appropriate criticism of how slow we were to recognize some of the evidence as it emerged in the COVID response. And I think similarly, using AI and other technology to make us faster in learning lessons, you know, gather the data, analyze the data, change our response when valid, right? When based on actual data and good analysis, that's what we want to do. And I think in both ways, on the communication and on the learning our lessons space, I think there's going to be some good opportunities.
So much that we've talked about this has been this always on readiness, and you know, as I mentioned earlier, it's more of a dimmer switch than it is an on off switch. And I know one of our challenges across the board is sort of when do you move to that next level of response? And I do wonder if, you know, AI can be helpful there, and thinking through kind of what do our baselines really look like inside of a community? What should triggers be that can be data informed and data driven, so that we're not all wondering, you know, when do we pull that trigger to have the big broad coordination call, the first one, but instead it's you know, it's pretty much more clear to us about when we do that. Any other thoughts, Onora, Vikram?
Yeah, I think so, Melissa. You know, especially in our world, the AI component is fairly underutilized, and there's a lot of room to grow there. You know, just in terms of data mapping and trying to figure out which communities are at higher risk, so we have an equitable response. The load balancing stuff that Onora was mentioning is still a very manual process, and there's no reason to have this done by a person. It should easily be able to be done by LLMs and large language models. So I think it is an untapped potential, and I think we still have to figure out how to exactly use them, but it's time to couple up a little bit more. Thanks.
I love your idea, Melissa, and I'm still learning a lot about this space and its potential, but I love the idea of where it can help us inform baseline information. I think that's great. Maybe expedite and ease the data collection or data analysis information. I will also say, I think we always have to just be willing to take a good gut at what's going on and a willingness to lean in, hopefully informed by good data. I think there's maybe potential in the opportunity for training and helping to advise frontline clinicians on different things, whether it's infectious disease, maybe new ways of thinking about questions, prompting questions to ask from a travel perspective, you know, especially in organizations that aren't large multi-specialty organizations, but maybe more in our frontline or rural communities, ways that it might help, again, providers that have to be generalists in a lot of things, maybe have access to a little bit more specialized knowledge and the prompting the questions and the things that they should be thinking about. Or I don't know, I imagine if that's already being done and I'm just not tuned into it enough, then that's awesome. But there's probably a lot of ways that we can use it. And I think we need to be really creative.
Another value of coalitions such as this to bring those promising practices to the forefront. So Well, I want to thank all of our panelists here. All three of you really brought up such outstanding points, and even more than just your answers today. Just thank you so much for the work you've done to strengthen the readiness inside of all of your communities and truly nationally, with the amount that you share with all of our colleagues to help spur some ideas in them. And I think we all know this is not an easy field. It's 24/7, and can't thank you enough for everything that you've dedicated throughout your entire careers to readying the United States. With that, I'm going to turn it over to Chelsea Cipriano now to close us out and tell us a little more about how to engage with the Common Health Coalition.
Thank you so much, Melissa. Thank you, Paul, Onora, Vikram. So amazing to have all of you on. I think it's hard sometimes when we talk about the coalition and this work of making it tangible and making it like actually feel real outside of an exacerbation, but also during it. Like, what does partnership mean in this context? And I think conversations like this, but also just having the opportunity to highlight the work that's happening in each of these areas makes it tangible. So our goal for today, as you stated at the top, Melissa, was for folks to hear this and take away to their own communities and organizations some either new information or an idea of what they could be implementing in their own institutions, even absent these more formal structures. Maybe they want to build them. I look forward to seeing the next network like Onora's somewhere else in the country. So I think with that, I don't have much more to say. The Common Health Coalition, Dave gave a great overview at the top. It's free to join for organizations who are committed to this partnerships between healthcare and public health mission. And there's, we can go to the next slide. There's some links and QR codes on the next slide that should take you where you want to go. You can join us as an organization. Again, it's free to join. We do things like this where we highlight your work and really elevate it for others to learn from and to learn from each other. Our upcoming events, this is our website in the center. We have a LinkedIn, and we have an ongoing Common Health Challenge that we have annually. This is the inaugural one, and this year it's focused on community health workers, really as the bridge between healthcare and public health. And immense drivers of trust in this country, which we could use now more than ever. So with that, I won't belabor this much. If you are interested in joining the coalition, you haven't already with your organization, feel free to reach out for more information or just follow this link. So thank you to all of our panelists. Thank you, Melissa, as always, for being a great advisor to the coalition, but also just a leading mind in this field. We couldn't do this without you.
Chelsea, thanks to everything you've done to build the coalition.
Thank you. All right, everyone. Have a great day.
Thank you.
Great. And this will be recorded if you want to listen later. I should have mentioned.